Hi, my name is Ellen Keeley, and I am an interventional cardiologist at the University of Florida in Gainesville. I also serve as faculty and have recently joined the committee as one of the course directors for the CVI's annual Intervention and General Cardiology Fellows Program. Welcome to CVI Heartbites. CVI Heartbites is a free, non-accredited educational program produced by the Cardiovascular Institute of Philadelphia, featuring succinct presentations delivered by leading experts on timely topics in cardiovascular medicine. This CVI Heartbites segment focuses on cardiovascular disease in the age of COVID-19, and I specifically will be speaking about management of acute MI. Please note this presentation was recorded on April 23rd, 2020, and the information was up to date as of that time. At the end of my presentation, you will see some additional resources and have the opportunity to contact me with any questions you may have. So for nearly 15 years now, primary percutaneous coronary intervention, or primary PCI, has been considered the reperfusion strategy of choice for patients who come in with an ST elevation MI, and this is if it's done by experienced operators in a timely fashion. This has been given a Class 1 indication by the American College of Cardiology, American Heart Association, guidelines with level of evidence A. But with the new reality of COVID-19, there are some things that really we need to consider in performing primary PCI. And the considerations are the fact that, first of all, because it's an emergency procedure, we really won't know necessarily the COVID-19 status of patients. And so that's something to keep in mind unless we get very rapid testing. The second is we have to be thoughtful and concerned about cath lab staff availability and actually cath lab availability, depending on whether we have surge of the disease or sickness going through our cath labs. So that has to be considered. We also have to worry about possible shortages of personal protective equipment, which is very important and must be used while we are in the cath lab. And the fact that many cath labs don't even have the ability to turn the cath lab into a negative ventilation room. So that has to be considered as well. So whether or not any of these considerations or issues may result in delayed reperfusion in the patient or spread of the disease, again, is something to think about. And in response to this, the American College of Cardiology Interventional Council and SCI put out a joint statement in March of 2020, published in JACC. And in that statement, one of the sentences says that in COVID-positive patients without contraindications to thrombolytic therapy, that can be considered if the patient is of low risk. So since the last time I myself administered thrombolytic therapy was more than 11 years ago, when I was at the University of Virginia at the time, and we had a blizzard. And by the way, the patient required rescue PCI at the time. And since I know for a fact that most cardiology fellows, at least in the programs that I've been associated with, can go through their whole entire cardiology fellowship never having ever needed to administer thrombolytic therapy, I thought that this is a very good opportunity and a very timely, in a timely fashion, to review the literature regarding thrombolytic therapy and primary PCI. So we know that for thrombolytic therapy, when it's compared to placebo, patients who were treated with thrombolytic therapy have improved left ventricular function and decreased mortality. And despite the ease of administration and its widespread availability, there are definitely limitations to its use. So first of all, 30% of patients who come in with an ST elevation MI will have a contraindication to its administration. 15% of patients who receive thrombolytic therapy will not reperfuse and will require a rescue PCI procedure, which is what the patient required when I did give it 11 years ago. And that means that the patient needs to go to the cath lab emergently with full dose lytics on board, and you try to open up the artery. And another 25% of patients will initially reperfuse, but then will reocclude and have a second heart attack, most likely needing to go to the cath lab. So there are a total of 23 randomized controlled trials of primary PCI versus thrombolytic therapy that have been published. And with about a total of more than 7,000 patients randomized to either arm. And I thought it would be good to review some of the data from the meta-analysis that was published in Lancet in 2003. And what this meta-analysis did is to compare the short-term and the long-term outcomes in patients who were treated with primary PCI versus thrombolytic therapy. And I'll draw your attention to the top part of the screen here. We'll look at the short-term outcomes first. The patients who were treated, this is more than 7,000 patients randomized to primary PCI versus thrombolytic therapy across all these studies. And the white bars are the patients treated with primary PCI, the gray bars, those treated with thrombolytic therapy. And what you can see in the short-term outcomes is that patients who were treated with primary PCI had significantly decreased risk of death, and that remained true whether or not the data from the shock trial was included. They also had significantly decreased rates of non-fatal MI, of recurrent ischemia, of total stroke, of hemorrhagic stroke, and of death, non-fatal reinfarction or stroke combined endpoint. The only outcome that primary PCI did worse than thrombolytic therapy was major bleeding. Remember, this was not intracranial bleeding. This was not intracranial hemorrhage. This was major bleeding. The vast majority were from the access site, which in those days was the groin, because these studies predated the radial approach. And in those days also, we would use larger size sheaths than we normally would today. So now let's look at the long-term outcomes. So again, these are patients who were treated with primary PCI in the white bars and thrombolytic therapy in the gray bars. And long-term outcome, usually about 1 year when the trials reported their outcomes. So we found that the patients treated with primary PCI still had significantly decreased risk of death, whether or not the shock trial treatment, with the shock trial data was included. They had significantly decreased rates of non-fatal MI, recurrent ischemia, and again, the combined endpoint of death, stroke, and reinfarction. So in summary, for every 50 patients with ST elevation MI that are treated with primary PCI instead of thrombolytic therapy, you can save 1 life and you can prevent 2 complications, and those complications can be things such as intracranial hemorrhage. But we have to remember that it's only as good as, the procedure is only as good as the people providing it and the time that they're providing it. So this is data from registry looking at mortality on the y-axis and minutes to reperfusion on the x-axis. And as you can see, in patients who there's a delay to the cath lab or a delay of getting the artery open, there's increased mortality. So that brought up the whole concept of facilitated PCI. Now, what facilitated PCI is the idea is, well, what can we do while we're waiting for the cath lab to come in? You know, we've activated the lab and the patient's on this way, but what can we do? Can we give them something in the interim before we open up the artery mechanically with the balloon and stent it that might help? The theoretical benefits would be that it might improve initial TIMI-3 flow. It may improve microvascular flow. That might lead to decreased infarct size, improved LV function, and improved survival. The theoretical disadvantages is that, well, it may increase bleeding because you're giving medications up front that are antiplatelet type and antithrombotic type medications. It might increase risk of intracranial hemorrhage, and also the cost will be increased. So in terms of the data behind facilitated PCI versus thrombolytic therapy, there are 18 randomized controlled trials. There's a meta-analysis that was performed of the 17 randomized trials, and I will show the data for the 18th trial that was not available at the time of the meta-analysis. This data looks at 4,500 patients over the 17 randomized trials that were, these patients were randomized to either standard primary PCI versus a facilitated PCI approach. And the outcomes were both clinical and angiographic. This data was published in The Lancet in 2006. The trials that were included in this meta-analysis included those that used 2B3A alone as the facilitating agent, those that used thrombolytic therapy alone as the facilitating agent, and 2 that used a combined of a reduced dose lytic therapy and 2B3A inhibitor before PCI. So what was found is that facilitation actually did improve the initial TIMI-3 flow. So this is before PCI, so this is initial TIMI-3 flow rates, and this is after, or final TIMI-3 flow rates. The y-axis is proportion of patients with TIMI-3 flow on angiography, and then the x-axis we have 2B3A alone, lytic alone, the combined therapy, and then all trials together. The dark bars, blue bars, are the patients treated with facilitated PCI, and the aqua-colored bars are those treated with standard primary PCI. And what you can see is it is true that whether you gave a 2B3A inhibitor alone, lytic alone, a combined lytic and 2B3A approach, all of those approaches resulted in better initial TIMI-3 flow rate than did primary PCI itself. However, at the end of the procedure, the TIMI-3 flow was achieved in approximately 90% or so of all patients, regardless of what they received or didn't receive prior to the cath lab. So what about the hard endpoints? Well, this is the data regarding death in facilitated versus primary PCI. And it's broken down by those that use platelet glycoprotein 2B3A inhibitors, those that use thrombolytic therapy, and those that use the combined 2B3A and thrombolytic therapy. And what we see, compared to facilitated PCI, primary PCI had regimens had a decreased risk of death, decreased reinfarction, decreased need for urgent target vessel revascularization, and decreased risk of major bleeding, all favoring primary PCI, not facilitated PCI. In addition, the risk of stroke, whether it be hemorrhagic or total stroke, was significantly elevated in the facilitated PCI arms that gave thrombolytic therapy compared to patients who just received primary PCI. So both total stroke and hemorrhagic stroke were significantly elevated in the facilitated PCI arms in full-dose thrombolytic regimens compared to primary PCI. This is the 18th randomized controlled trial called the FINESSE trial, which was completed and published about 2 years after the meta-analysis in the New England Journal of Medicine. And what this trial did was enrolled about 2,400 patients into 3 arms. One was a primary PCI arm. One was apixaban facilitated, so they received apixaban prior to PCI. And then the third arm was a combined, what they called a combination facilitated PCI. And what this arm consisted of was 2B3A of apixaban plus half-dose retiplase. These patients all presented less than 6 hours after symptom onset. The primary endpoint here is a combined endpoint of death, ventricular fibrillation, shock, and heart failure at 90 days. And what you can see is there was no difference at all when you compare all three regimens. And in fact, the regimen that had the thrombolytic arm to it, the combination facilitated PCI that had the 2B3A plus the half-dose Retaplase, had increased risk of major hemorrhage. So what we know about primary PCI versus facilitated PCI is that the pharmacologic pretreatment prior to PCI actually does improve the initial TIMI-3 flow, but it resulted in neutral clinical outcomes in those patients who received upfront 2B3A inhibitor, and it resulted in worse clinical outcomes in those patients who received upfront thrombolytic containing regimens. So what about this concept of pharmaco-invasive strategy? We hear that concept out there now, and what that really means is that you plan to administer thrombolytic therapy, and then you are going to proceed with your coronary angiography, but you're going to wait. You're going to not go right away. You're going to wait for at least 3 hours, up to 24 hours after the thrombolytic therapy is on board, to take them to the cath lab. Of course, if you can't because the patient does not reperfuse, then they would require a rescue PCI. But the idea of pharmaco-invasive strategy is to try to give the thrombolytic therapy and then wait a bit before you have to take them. There is some data from some registries, but I will show data from a randomized controlled trial called the STREAM trial. And this trial enrolled about 1,800 patients. And what they did is they only enrolled patients who presented very early after symptom onset, less than 3 hours. And also, these patients were not going to be able to be treated with primary PCI within an hour. So they were kind of not at a primary PCI capable hospital. So what they did is, in that subgroup of patients, in that group of patients, they randomized them to primary angioplasty, so they would then get transferred to the PCI capable hospital, versus giving them thrombolytic therapy and then proceeding with angiography after 6 up to 24 hours later. And what they found is that at the endpoint at 30 days was a combined endpoint of death, shock, heart failure, and reinfarction. There was no difference between the two outcomes here, between the two regimens, no difference. But the important thing to remember is, number one, these patients presented very early, less than 3 hours, and which is the time when we think that thrombolytic therapy should have its best effect. Also, 36% of the patients who were randomized to thrombolytic therapy actually required an emergency rescue PCI procedure. And in addition, those who were randomized to the thrombolytic arm also had higher rates of intracranial hemorrhage. So in general, remember, if we're going to administer thrombolytic therapy, we have to remember that the patient needs to be loaded with aspirin, needs to be loaded with clopidogrel, high dose of atorvastatin, obviously needs a bolus of heparin, and then the heparin infusion. And at this time, if thrombolytic therapy is needed, tenecteplase is the agent that is preferred. Well, what about non-ST elevation MI in the COVID-19 era? That's very interesting, because we're seeing reports up to 20–30% of patients with that are COVID-19 with COVID-19 can have elevated troponin levels, and especially when we're using the high sensitivity assays. And it's going to be the responsibility of cardiology to try to figure out who's having a type 1 non-STEMI, because we know what guideline-directed medical therapy is required, and of course angiography for high-risk features, and we know what to do with type 1 non-STEMI. But which patients are actually having a type 2 non-STEMI, especially if they're COVID positive, because we know that a lot of patients are going to the cath lab and they're having wide open coronary arteries, and the diagnosis is most likely some sort of myocarditis or Takotsubo syndrome. And in those patients, it's going to be very important to try to determine who really does need to go to the cath lab and who doesn't, and who should we treat with the guideline-directed medical therapy, which makes it a little bit more difficult. But what is recommended right now is if we really are certain that this is a type 2 non-STEMI, we need to treat the underlying condition and try to be conservative and not take COVID-positive patients to the cath lab with a known type 2 non-STEMI, unless, of course, they are unstable. So in summary, primary PCI is the preferred reperfusion strategy for ST elevation MI. And I think it's important that we have this opportunity to review the data that supports that. Yes, there's going to be times when thrombolytic therapy, especially in the COVID-19 era, thrombolytic therapy would be the right treatment of choice. We just have to remember what the contraindications are. We have to remember what the limitations are. And we also have to remember that administering thrombolytic therapy will not necessarily result in less resource utilization, because most of these patients will end up going to the cath lab anyway, or at least a proportion of them will. Those who will not reperfuse, or those who reperfuse and then will re-occlude. So we have to remember that. And then also, importantly, we have to remember that in the COVID-19 era specifically, we're seeing a lot of cases that patients come in with classic ST elevation, elevated troponins, symptoms consistent with an ST elevation MI. They're going to the cath lab only to find out that their epicardial coronary arteries are wide open. And so I think it's very important that so on one hand, we have to be careful because we're taking the patient with COVID positive to the cath lab, and of course we have to be careful with that. But on the other hand, if we give thrombolytic therapy to these patients who are not having an ST elevation MI, it could actually make things worse, especially if they have myocarditis. We can cause bleeding into the pericardium or into the myocardium. So we have to really think about these things, and that's why I think it's important to review the literature and to consider these things now that we're dealing with COVID-19. Here are some additional resources on the management of acute MI in the COVID-19 era. If you have any questions for me, please email CVI's Executive Director, Mark Hartnett, and he will send the questions to me. Please feel free to share this link with anyone who might be interested in the information, and please let us know if there are other topics of interest to you. Thank you for watching the CVI Heartbites segment, and for more information on CVI Heartbites segments as well as other CVI educational programs, please visit us at cviphiladelphia.org or follow us on Twitter.